thalamus is a common area where you get bleeding in the brain, a type of hemorrhagic stroke. All right, usually related to high blood pressure, hypertension. Okay, so that's one of the causes for thalamic injury. Number two, sometimes you can get tumors in the thalamus, thalamic gliomas, and usually it's quite bad news because, as you can see, the important neurons and all are located within. Surgical removal of thalamic lesions can cause severe neurological deficits here. So, common two things is bleeding in the brain from a spontaneous bleed, high blood pressure induced stroke that commonly affects the thalamus. All right. As for the hypothalamus, hypothalamic injury can occur because of trauma, head injury, high velocity injury, right? Causes shearing of the what I call it, the stalk and the hypothalamus. That's one, because it's sticking out downwards. Similarly, you can also get tumors in the hypothalamus. Extension of a tumor from the pituitary gland can affect the hypothalamus. After what do you call it? I mean, tumors anywhere. I mean, tumors, pituitary tumors, or you can even get tumors arising from the hypothalamus proper. It's commonly seen in children, something known as a craniopharyngioma. So these are some of the causes of injury to the hypothalamus and thalamus. Yes, as you rightfully pointed out, the cerebellum is can be injured in trauma, but actually the commoner injury to the cerebellum is actually also due to hemorrhagic stroke. Because the cerebellum is, other than the thalamus, is also a common place where you get bleeding from high blood pressure, when your blood pressure is not adequately controlled.
Okay, all right, thank you. One more question, because the hypothalamus is such a small structure in the brain, right? And it contains so much nuclei in there.
Yes,
and it
yes.
so many functions. And when an injury happens to the hypothalamus, usually does it affect all the nuclei and all the functions that are involved?
It really depends what extent of the injury. So if it's a small area of injury, like it's sometimes just a small blood vessel is affected, the commoner things you see in hypothalamic injury is you will see water balance dysregulation is very common, especially acutely. You will see that they start passing out large volume of urine, and their sodium balance gets called haywire. Alternatively, if it's very severe, the patient even can end up unconscious. They can get hypothalamic temperature abnormalities, meaning they have like persistently high fever in spite of them not having an infection, because the heat regulation mechanism of the body is affected. All right. You can get dysautonomia, means your autonomic function goes a bit haywire. So your blood pressure goes very high and then suddenly drops very low. It yo-yos up and down, up and down. So those are some of the examples of hypothalamic dysfunction that we see. Eating behavior and then sexual dysfunction, poor delayed development of sexual function or loss of interest tend to be more chronic. It takes the time to occur. So usually these are the ones that you commonly see in the initial phase.
All right, thank you.
Thank you. If you notice, I'm sharing an image of the brainstem. Before I just we are going to before I complete this, the first part of the module, we have covered cerebellum, thalamus, hypothalamus. You notice I'm not putting up many slides on the brainstem. This is going to be the main work for the next time we have a class. All right, I'm good. I will give you a brief description on the brainstem, but I want the other group members to sort of to do some work class, some research on things. See, okay, now we have learned about the deep structures, the cerebellum, the thalamus, the hypothalamus, right? Now, the thing that connects the cerebrum and all these other parts of the brain with the spinal cord is known as the brainstem. So the brainstem has three components. One is right on top is the midbrain, rightfully named because it's right at the center of the brain. Below it is the pons, I think, which is the Latin word for bridge, because it looks like a bridge connecting the midbrain and the medulla. And lower end is the medulla oblongata. So as I've given you briefly earlier, sir, the brainstem contains all the nerves from the brain going into the spinal cord, number one. So as important as thalamus, the brainstem is more important. It also contains the nucleus of our respiratory and cardiac function or heart function regulation. It contains the neurons that control consciousness, the reticular activating formation. All right. It contains the nucleus of our cranial nerves. Like the midbrain contains the third and fourth cranial nerve nucleus. The pons contains fifth, sixth, seven. Border of the pons and the medulla oblongata, you got your 8. And then in the medulla, you have your 9, 10, 11, and 12 cranial nerve nucleus. All right. So depending on which part of the brainstem is affected, you can have differing symptoms. If you have a problem with your midbrain, for example, your third nerve, your oculomotor nerve is the one that gives rise to eye movement. So that's why if you have a third problem in the midbrain and it's not very big, you will get a third nerve palsy. That means one eye droops downwards. You have double vision because the nerves that supply our eye movement is affected. If you have a problem in the pons, you can get numbness over half your face. You get weakness on one side of your face, which I'll show you in the clinical lecture after this. Drooping of, we call it facial palsy. If you have a problem with your lower cranial nerves in the medulla oblongata, you have problems with your speech, phonation, production of sound, not the content, but the production of sound. You have difficulties in swallowing, right? Because the 9th, 10th cranial nerve supplies our pharynx, our swallowing mechanism, right? You can have abnormalities in pronunciation because the muscles of the tongue from the 12th cranial nerve are affected, right? So depending on where in the brainstem you have a lesion, there's variation in its neural function. So the group that's going to be doing brainstem has a bit more work. So you can put 2 groups for this. One, they go through the parts and the nerve nucleus, which I've already sort of summed up for you, and a cross section of how the midbrain cross section would appear, cross section of the pons, cross section of the medulla oblongata. Okay, so you all have now in total 3 + 2, 5 assignments. So you got to break your group, your members up into small groups to do this. So each group will take anything between 7 to 10 minutes. All right, because if it's too long, then it'll be difficult. I'd like everybody to interact. You can use the models provided in the USM facility in KL, or you can use PowerPoint or something. But I rather you use the model and you speak, right? Because that is the better training for you all rather than just using the slides. All right. Okay, guys, I'm going to close this down a while. Go back to where we were. So this is the last part of the first session today morning. All right. We have covered cerebellum, thalamus, hypothalamus, and brainstem, which you are going to I've given you an overview. I want to give you some assignment related to that. Okay, guys, we are going to do, I'm going to give you another 5 minutes break before we go into clinical manifestation, all right, of disease. You need to understand the anatomy or behind the function. So we are talking about vision first. All right. So our eyes are our important, as you all know, the key organ involved in vision. But it's not just the eyes, but the eyes interaction with brain that allows us to process visual information that is received. So the eyes is the organ where the visual information comes in. Guys, can you all see the slides?
Doctor, we can't see the slide.
Oh dear. Okay, let me restart.
Cannot see, doctor.
Stop. Start balik. Where has it gone? Now? Can you all see now?
Yes, doctor.
Yes, doctor. We can see.
Very good. Okay, great. So that's it. First, we have to understand the anatomical structure that's responsible for vision. So first here is an image of your eyeball. So what does the eye or the eyeball do? Image in visual information comes in the form of light, which is focused into the eye. It passes through the anterior chamber, through the cornea, and passes through the lens. What the lens does, it focuses the light and relays it to the posterior part of the eye, a layer known as the retina. The retina contains nerve fibers that and photoreceptor cells. Photoreceptors are cells that are sensitive to light. You have black and white and color photoreceptors. So when light hits these photoreceptor cells, they will cause the generation. I mean, very simply put, there are actually 10 layers of the retina, which influence how we see, color, depth and all, but I won't go too much into that. But essentially what happens is it triggers an electrical impulse in the retina nerve fiber layer, which all result in the creation of an impulse in the optic nerve. Okay, so the information from our vision, the light that reaches the retina, is relayed through the optic nerve to the brain. Okay, so we're going to talk about the optic pathway. So before that, so the retina is the layer of the eye which receives these visual inputs. All right, you have a neural layer and a pigmented layer. The pigmented layer is over anteriorly, and the neural layer is behind it. Okay, so and when you look at the eye, sometimes doctors put a fundoscope and look into the eye. This is what we see. We see all these arteries, right? The center area is known as the optic disc, which is where the optic nerve arises from. So all the vision is related to this part. Okay, so visual pathway. So when light hits our retina, all right, it is in the opposite direction, meaning visual, something you see outside, all right, it hits the inner retina, opposite. Something near our nose, our nasal field, hits the outer part of the retina. Why you need to even know this is because the information from the inner retina is carried and it crosses to the opposite brain. Information from the outer part of the retina, meaning from the nasal field, does not cross and is carried to the same side of the brain. So because of these differences, you will have a very difference in the type of visual deficit you get if you have a problem in the visual pathway. All right. So here, I mean, in the text here, I'm talking about something called your rods and cones. These are your photoreceptor cells. Rods are for black and white. Cones are for your color vision. Right. So they will detect the light information from the retina, and then they form, they trigger bipolar cells. Then these bipolar cells will initiate a neural response, the ganglionic cells, and these ganglionic cells all give rise to the optic nerve. From the optic nerve, the optic nerve will meet and form something called the optic chiasm. All right. Here in the optic chiasm, the fibers from the eye split into half. We say the medial group of fibers, they cross to the opposite brain. The lateral group of fibers, they stay on the same sides. So this will give rise to interesting differences in visual deficit. That means what we cannot see, depending on which part of this pathway is affected. It's a very, very typical pathway. You can predict exactly where the location of the problem along the vision if you understand this anatomy. All right. I'll show you a slightly easier picture before I come back. Okay, so before we talk about the deficit, so you see, visual input from the eye is carried through the optic nerve. All right? Optic nerve can be divided into two halves. The fibers on the medial half, which carries the temporal field, it will cross to the opposite side of the area known as the optic chiasm. The fibers that carry image from the nasal field, the inner part, which is the outer fibers, it's opposite, will not cross. At the optic chiasm, they just move posteriorly to the brain, and this part of the thing is known as the optic tract. So optic nerve, then it goes to the chiasm, divides, and then it gives rise to optic tract. The optic tract will go to the lateral genicular body. This is part of the thalamus, right or not? Now from the thalamus, it relays through the parietal and temporal lobes. This structure is known as optic radiation, and finally it will reach the occipital lobe, which is the visual cortex, right? So, and you find that the way it's arranged is very typical, whereby, see, the parietal lobe is on top, but the part of the visual information that is carrying is the inferior visual field. So it's always the opposite. The temporal lobe is located below, but it carries the superior visual field, right? And finally, they all reach the occipital lobe, which is the visual cortex. So you see, once again, this is the eye. You have the nerve fiber, retinal nerve fiber in the outer part, which carries the nasal information, the nasal field, field of vision. That means what we can see on the nose or near the nose. The nerve fiber layer on the inner part actually looks opposite to the outer field. So this is carried through the optic nerve backwards, then it divides. Fibers from medial side, the outer field, cross to the opposite side. Fibers from the visual field, from the inner part, the nasal field, they don't cross and they go straight to the brain and they form the optic tracts. And optic tracts go to the lateral genicular body. It gives rise to optic radiation that runs through the parietal and temporal lobe, finally to reach the occipital lobe. Guys, this is something kind of, interesting thing that can be asked in your OSCE, so good to pay attention. I can repeat for you all later. So your visual cortex, finally all this information from the eye to the optic nerve, to the optic chiasm, to the optic tract, and then from the optic tract to the optic radiations, and finally you'll reach the occipital cortex. This is Brodmann's area 17, right? And then you have your secondary visual cortex is your area 18 and area 19, which is involved in integration of visual information. You have your dorsal and your ventral stream, which we'll talk about later. Now, besides going to the brain, information that hits when your visual information that reaches the retina just doesn't only go to the visual centers. It goes, through the lateral genicular body, it goes to the primary visual pathway, correct? But it also goes to other places like the pretectal area involved in what is known as the light reflex. The light reflex is a reflex that changes the diameter of our pupils in accordance to how much light is around us, right? So in a dark area, our pupils will dilate because it's trying to get more light. Then you also have the suprachiasmatic area. This is near the hypothalamus. So remember, suprachiasmatic nucleus of the hypothalamus. So information from the retina, light also goes to this nucleus, which tells us, whether it's daytime or nighttime, circadian rhythm, our body's wake-sleep cycle, and, has an influence on endocrinological function because the hormones are produced in response to our wake-sleep cycles, all right? Similarly, it also, when information reaches the retina, it is relayed to this area called the superior colliculus, which is part of the midbrain. This part of the midbrain, it coordinates our what is known as conjugate eye movement and head movement. Okay, what does this mean? Now, our eyes need to move at the same time in order to maintain that we always have one image we're looking at any given time. If the two eyes work on its own independently, what will happen? Everything you look at will look like double, right? And this must also go in tandem with our movement. Imagine you are looking straight, but your head is turning. But do you realize right now, if you're looking at the screen, all right, but you turn your head, your eyes can still keep focusing on the screen even though your head is turning to the right? I'm sure those of you who are trying it, you'll realize, correct or not?
Yeah.
You're not telling your eyes to do that, but your eyes know exactly what to do because this is all the coordination that occurs between our eye muscles and our head movement. So that's why, see, the information that comes from our eyes doesn't just go straight to the brain only for processing. It goes to other areas for coordination, of our function, which even we don't realize. Okay, guys? So I'm going to, so this is a recap of the visual fields that I spoke to you about, how the information is carried. So imagine your eyes, your field of vision in each eye is divided into half. The blue one is the nasal field. That means what you're seeing near your nose. And the red one is the temporal field. That means the outer half of the vision. Okay? So visual input from the nasal half will go to the outer half of the retina. That's how the light travels, right? Not. And visual information from the outer half, we say the temporal field, will hit the retina, in the inner part of the retina. So these fibers are carried together as the optic nerve. But when you reach the optic chiasm in the center, it divides. So the visual information from outer half will cross to the opposite side, to the opposite optic tract. Visual information from the nasal half will remain on the same side and cross over. And they all reach the lateral geniculate body as the optic tract. So remember, optic nerve, optic chiasm is where they cross. Then they form the optic tract till the lateral geniculate bodies. At the lateral geniculate body, it will give rise to a second order neuron, which is known as the optic radiation. So this optic radiation gets spread. If you look at this image here, prior to this is all concentrated. Optic radiation gets spread. So visual input from the lower half of our field, it's divided in half. Imagine atas and bawah. The lower half will go to the parietal lobe, as the optic radiation, the parietal lobe, while the upper half of that half field will be carried in the temporal lobe, right? And this is the optic radiation. So that's why, depending on how the visual field defect occurs, because we divide each eye into 4 quadrants, depending on which quadrant is affected, you can actually predict where along the pathway the problem is. Is it at the optic nerve? Is it at the optic chiasm? Is it at the temporal lobe, parietal lobe, and occipital lobe? So this is something very important that we always teach our young medical students. I think it's very relevant for you all to also understand and appreciate this, because, especially when you have a brain disorder, based on the visual field loss, you can also predict where the location of the brain problem could be. All right, guys?
All right.
Focus on this image. I think it's a very important image for you all. So just say you have a problem. Okay, imagine your visual fields can be divided into right eye and left eye. Okay, so normally you should be able to see all 4 quadrants. So if you have a problem of something affecting one eye, just say, all right, then you will get, like, see G, the left eye, something cuts off the optic nerve. So you lose vision in that whole eye. Okay, so left eye optic nerve problem, complete left eye blindness. Very easy. Right eye can see. Okay, you don't bother about this. Then, if you something affecting your optic chiasm, which is H, okay, you will get loss of the outer field, the temporal field. Right. So both eyes, you cannot see the outer half. Why? You may remember the information from the outer half reaches the medial retina, and that is the fibers that cross. Okay, so this is known as bitemporal hemianopia. All right, so if you have a problem in the chiasm, your both eyes cannot see the outer field, you can only see the inner field. Okay, are you all following?
Yes.
This is important. Okay, now if something is affecting your optic tract, that means behind the optic chiasm, right? Then what will happen is you have the fibers. Okay, just say it is on the where's your eye? Something affecting, okay, on the left, this side. Okay, so what will happen? You will lose the temporal field, right, on the right, and the nasal field on the left. So this is known as homonymous hemianopia. If you look at over here, so just say the lesion is on the left, you lose the outer field on the left side and the inner field on the right side. Does that make sense to you all? Because of the crossing fibers. Just say something more distal, as it's going nearer to the occipital cortex. If the parietal lobe is affected, then what will happen is only the lower part of the quadrant will be affected. Because remember, in the earlier picture, if only this area is affected, then you will only get a lower quadrant. If only this area is affected, then you only get a lower quadrant deficit like this. If it is a temporal lobe problem, you will get an upper quadrant problem. All right. So that, see, J, why is J and K different? Because J is on the right. So if you have a right-sided pathology in the temporal lobe, you will get a loss on the right side, right homonymous hemianopia, or here is right quadrantonopia, superior quadrantonopia. That means one quadrant is affected. The lower one, if it's a parietal lobe pathology, because it's reverse, it will cause an inferior quadrantonopia. Okay. And lastly, if it affects the visual cortex, you can completely lose the whole vision, similar to this, or sometimes you can have sparing of just the central part of the vision. That's the difference between this and this. So guys, if you're given an image like this, do you think you will be able to identify, okay, the cut here, how will the visual field be defect be? A cut here, how will the visual field be defect be? A cut here, how will the visual field defect be? Will you be able to do that?
We need to study first.
Very good. So this is going to be one assignment for you all. I think you will be happy to do this assignment, okay? The visual pathway, just this diagram, and where, how do you define the deficits that you will see, okay?
Doctor, will this be an individual assignment?
This is, yes, it will be good if you all do it individually. You can do it in a group also, I don't mind. But I would like to stress that it's important that everybody does it. Can or not?
Now,
Okay, good. This is important, interesting to know. Okay. Try not to focus on the top field because this is an overview. See, visual field defects can also occur due to problems in the eye proper, not just the nerves. So I'm focusing on the lower half because these are all nerve-related problems. If you have a problem in the retinal fiber layer, you can have a central defect where the blood supply to that one particular area is affected, then you get a scotoma. If you part of the nerve fiber bundle, half of it, which is not neural usually, is due to ischemia, you can get altitudinal defects, So don't bother about this so much. More of the visual field defect that you get in depending on the lesion in the visual pathway. All right, guys? So remember, optic nerve, before the chiasma, you completely lose vision in that particular eye. So left optic nerve lesion, left eye blindness. When the problem is in the chiasm where there are crossing fibers, then you will get bitemporal hemianopia. That means you cannot see the outer field. Once you have crossed behind the chiasm, then you will get what is known as homonymous hemianopia. Means half of it is temporal, half is nasal. So how do you remember? So just say you have a left-sided lesion, you will get right-sided homonymous hemianopia. That means you are not able to see the outer half, on the left and the inner half on the right. Okay, like this. If you are more backwards, affecting only the parietal lobe, then only the lower half is affected, inferior quadrant. If it's only the temporal lobe, then it's only the upper half, the superior quadrant. And of course, occipital cortex can be completely homonymous, or sometimes there will be a central area of sparing, macula sparing, that's the word here. Okay, so this is another assignment for you guys. Though it's all very small little things, but little pockets to focus on. So, yeah.
What about glaucoma?
Sorry, see, glaucoma is usually a problem where there's a build-up of pressure in the eye. All right. So what happens is there's ischemia to the eye. So because of that, the retinal nerve fiber layers will not be able to, the thickness or the viscosity of the fluid and the high pressure in the eye does not allow adequate pick up by the retinal nerve fiber layer. So you get blurring of vision. See, there are different types of visual problem you'll get. You have problem called visual acuity problems. Okay, visual acuity problems are, that means when you look at an image, you can see, but it's blurred. All right. Visual acuity problems are commonly due to eye diseases. Like, how many of you are short-sighted? Quite a few, I would imagine, wearing spectacles, right? So those are all problems related to the eye itself and the lens, the mechanism of which visual images are focused on our eye. Okay, so those are problems of acuity. Then you have visual field problems. That means, you see, if you look straight right now, imagine each eye, the whatever you can see is divided, is like one big circle, and it's got 4 quadrants. So each of the quadrants have nerves that carry the information to the brain. Now these nerves are, as I said, divided in such a way, they divide here, they split, so that if you have a problem in your a certain part of the visual field, not the whole thing, it could be the nerve fiber that's carrying information from just that area is affected. Okay? Then
Doctor, I would like to ask you regarding if connected with the limbic system. When I read it, that sometimes you have anxiety and fear also giving visual problems. So is that also connect with the nerve fevers, or
You have to be a bit more specific. What do you mean by visual problems? That's a very wide term. There's
Okay.
so many different types of visual problems. Okay, so like I said, problems of acuity are unlikely related to emotional issues. Okay,
Okay.
unless maybe you have tearing and that causes blurring of vision because the ability of the light to reach the retina is affected. Number one. Number two. Visual field deficits, like what I'm just describing right now, also unlikely to be emotive in nature due to limbic pathologies. Okay, then we move. Usually, if there were any emotive effect on the vision, it should be related to a higher mental cortical processing. All right, that's where the occipital lobe, together with the sensory association areas, process visual emotion. So, I mean, visual information. I'm coming to that deficit. Just hold on. These are more basic visual problems. Problems of acuity, blurring of vision, problems of field. I give you an example. Imagine if you look at an image, but half of it is black. It's like somebody covers half your eye with a black cloth. That is what a visual field deficit will look like. All right. Then you have so you see, similarly, depending on where the lesion is, so this is like just one half is gone. So in both eyes, one half is the outer half, one is the nasal half. You realize this or not? So this is a homonymous hemianopia. Fibers usually behind the optic chiasm. If you have a quadrant problem, these are usually pathology in the temporal lobe if it's superior, parietal lobe if it's inferior. Okay, and if the problem is in the occipital cortex, then you have the complete loss, but sometimes the central area lobe is spared. This is called macular sparing. Okay, so what are the things we will test when we're testing vision? We will look at visual acuity. That means the clearness of the image. You can see, but how fine is it? We'll assess your color vision. We'll assess the fields of vision. That means, you divide your eye into four quadrants, and you're going to see whether you can see all four quadrants. Then reflexes are your pupillary reflexes, and fundoscopy, we look at the back of your eye. So these are common things done in the standard examination of vision. All right. So visual acuity is assessed simply using something called a Snellen chart. You stand a certain distance away from the chart, and depending on how many lines you can actually read, then we know where your ability to differentiate fine words. So the commonest problem with this is usually some lens related problem where you require spectacles. Just give me a second. I think that my battery is running low. I'm going to just quickly connect it to the power supply. Okay, so here I'm just showing you. These are all just nice to know things. Color vision. This is how we test color vision using something called an Ishihara chart. Which identifies patients who are colorblind. I hope everybody in this lecture can see this number.
Yes, hopefully.
Yes, very good. Okay, further test. Now, can you all see these numbers?
7, 13, 16.
Very good. So nobody has depression, bipolar disorder, or stress. Okay. Next set. Can you see the three numbers?
8, 3, 9.
Okay. Does everybody can see all the three numbers?
I only see two.
I see.
Ha. Very good. You see? Man,
see the
it's just a
video.
joke. Actually, there's no number here. Haha. So, but anyway, good. So everybody's color vision is acceptable, right? Some even better than others. Okay, good. So let's move on. Okay, so what are the common diseases that cause this visual field defect? I wanted to show you something interesting. One of the common disorders that we treat in neurosurgery is known as a pituitary adenoma. It's a tumor that arises in your pituitary gland. All right. See this big white thing here. So this patients with this problem will have visual field defect, typically called a bitemporal hemianopia. See, the black area is what they cannot see when you test the vision. Okay, because the tumor grows up and compresses the optic chiasm, where the optic nerve crosses. Remember, I showed you in the earlier diagram. So we perform surgery through the nose for this. I just quickly fast forward to how the tumor will look. So this is the pituitary gland just before the dura. We learn about the dura. The dura is exposed. This is the bone of the skull base just below through the nose. And okay, so that yellow thing is how a pituitary tumor looks like. So that's what we do actually. We do perform the surgery to take out that yellowish tumor.
Yeah.
Okay, guys. So I don't want to gross you all out too much, but this is what we actually do on the non-hall Sundays, on all the other days of the week. Okay. So see, now, the disorders that I spoke to you about, the visual acuity problems, visual field problems, these are all problems related to the nerves that carry information from the eye to the brain. All right. But you can also get problems in vision if you have a problem with the higher mental centers that process visual information. All right. So these deficits caused by this damage to this area, you will have problems with visual processing, but your visual acuity and fields could be perfectly normal. All right. Okay. This is a complex slide, but I've put it in here so that when you all want to read, it's easy. But basically, this is the occipital area, and you have two streams called the dorsal and ventral stream. Basically, this is the neural networks are involved with how we process visual information. So you have two groups of information that's being processed. The ventral pathway, which is involved in or your magnocellular pathway, which is your dorsal pathway, and your ventral pathway is your parvocellular pathway. The dorsal stream, the magnocellular pathway, analyzes the where of your vision. Now your ventral stream assesses things like color and what. Okay, so what sort of problems will you get with this sort of disorders? Okay, so there are two important concepts here. One is disconnection of one part of the occipital lobe to another, and another thing is simultaneous occurrence. When you want to look at something, you only able to see. You need to see everything in entirety and both sides of the brain must register before you can recognize them. Okay, these are all nice to know. Do not worry. This is just for you all a bit of side reading. Okay, so here are some of the disorders of higher cortical function, just for you all to be aware of. So one thing, you can get something called alexia without agraphia. That means you are able to write, but you're not able to read. But see, what happens is the occipital lobe can see, but the connection between the right and left occipital lobe is affected, and your reading center is only on the dominant side. So that's why you get this alexia, without agraphia. You cannot write, but you are able to write, but you're not able to read, even though you can see. All right. Visual object agnosia. You look at an object, you can see it, but you're not able to recognize it. A form of visual object agnosia is, for example, something known as prosopagnosia. How often, if you look at a face that usually the problem you have is, I recognize the face, but I can't remember the name. Correct or not? Guys, yeah. But in people with prosopagnosia, you're not able to recognize the face, You know the name, but because the connection between the occipital and temporal lobe, where you keep your memory, is affected, your midfusium gyrus, you are not able to recognize the face and the memory of that face, how it looks like, right? Visual hemi-inattention. That means if you are looking straight, you can see everything in front of you, but whatever occurs on one half of your visual field, you ignore. This is known as inattention. All right. So this is due to parietal lobe problems, inferior parietal lobe, your sensory association area. And you also get there's some syndromes called balance syndrome. Now, you get condition known as simultagnosia. Simultagnosia means you don't recognize images when you're looking at something and there are two objects in your visual field. You are not able to register both of them. You only see one of them. But if tested separately, your eye is able to separately look at them. But the moment there are two objects, one side you don't see. So that's why simultaneously you are not able to recognize both objects. That's what simultagnosia means. Optic ataxia is a difficulty in following objects, even though you can see them. So these are all different type of abnormality of higher cortical function. All right, nice to know. I don't think you really at this stage you are just starting out on neuroanatomy, but just so that you understand, visual problems are so diverse. You can have deficits in your visual acuity, which usually related to your eye, the eye mechanism proper, the lens mechanism. Then you have problems related to the nerve, which usually typically cause visual field deficits. Or if it's the movement of eye movement control affected, then you get double vision or diplopia. Okay, so this is the common visual disorders that you get in brain pathology. Now we move on to motor system. This is simply the most common system that's affected in various type of pathology. All right. So in order to understand,
can I interrupt?
Yes.
I have questions about the visual neglect and also heminopia, right? My understanding is visual neglect is something like difficulty in processing one side of the body, right? Whether it's on the left or on the right, right? Heminopia is the vision problem itself, One is visual processing, another one is vision. So how do you differentiate that?
Let me correct this. Neglect is you are unable to process information from sensory information from one half of your body. You're correct. Neglect. Neglect got so many different types. There's sensory inattention. That means somebody touch your half of the body, you don't feel it, or you feel it, but your brain doesn't register it. All right. Okay. Number one. Visual inattention is you see something, but you don't. The visual information reaches your brain, but you don't process it. You understand or not? So neglect can be so many different types: motor neglect, sensory neglect, visual neglect.
Yeah.
But essentially, it reflects an inability of the brain to process sensory information from one half of the body.
Okay.
Okay.
All right. Thank you.
Sure.
Does it mean for visual neglect we can see those things, but it's just that we don't process it or don't make sense of it?
No, but you see, when you say that, when you talk about inattention, your mechanism of vision is working. You are able to see, but the brain doesn't register that you are seeing it.
Okay, so in understanding, we are like not seeing it.
Yes, exactly. But when you test, but you see, this is different from a blind person who's not seeing it. Okay. So we move on to motor system disorders. These are very common disorders. And before you understand the motor system disorder, you must understand how conscious movement comes about. So our primary motor cortex is where the neurons that give us, that activate our muscles to contract on our instructions start from. So these neurons will relay from the motor cortex down through the internal capsule. It does not pass the thalamus. Through the internal capsule to the brainstem, to the medulla. It crosses to the opposite side, and then it will reach the spinal cord at a particular level where, the whatever limb we want to move. Like, for example, if it is our hands that we want to move, then it will go to the cervical spine. If it's the legs that we want to move, then it will go down to the lumbar spine. And there it will trigger a second order neuron, right? A motor neuron that will innervate the particular muscle and make it contract. This is a very simple pathway. But of course, movement is not so simple because you need one muscle to contract. At the same time, you need the opposite muscle to relax, correct or not? Then only your movement will be good. And at the same time, you also need things like the cerebellum and basal ganglia to coordinate these movements, make sure everybody works, like on cue, so that, there's no, they don't fight with each other. And then the contraction and the relaxation of the muscles are just nice. So there's a fluidity in the movement, right or not? Okay, so if you have a problem with the motor pathway, so basically our motor anatomical function can be divided into two main groups of nerves. The pyramidal system is the one that comes from our motor cortex and is involved in conscious movement function. You also have the extra pyramidal system that involves the basal ganglia, which you're going to talk about soon, the cerebellum and the thalamus, which is involved in multi-step, pre-learned motor tasks, fine-tuning of motor tasks, maintenance of balance, right? You don't consciously activate these tracks, but they are working in the background to ensure the functionalness in our limbs, like half our body becomes weak. That's always pyramidal problem. If you have extra pyramidal problems, you may not have weakness, but you will have abnormal movements, abnormal stiffness, problems of coordination. So these are the two big ways, difference in how a patient will present to a doctor in practice. So when you talk about all these motor disorders, as I said, pyramidal tract problems are usually conscious limb weakness. Similarly, you also can get facial muscle weakness, all right? I'll show you some pictures of that soon. If the problem is of the motor nucleus of the cranial nerve of vision, then you get something called, you'll get double vision. So the cranial nerves involved in the movement of the eyes are the third, fourth, and sixth cranial nerves. So if there's a problem with any of these cranial nerves, then you get double vision. If there's a problem with motor function of the lower cranial nerves, the ones that supply our pharynx, our vocal cords, then you can get changes in your voice, difficulty swallowing, even difficulty breathing sometimes if it's both sides that affect. So non-pyramidal tract, extra-pyramidal, that's your basal ganglia, all the different tracts, cerebellum, you get abnormal movements, you get tremors, so many different types of tremors you can get. And then if it's cerebellar alone, you also add on, you get something called ataxia. Remember we spoke about ataxia, problems of balance, you walk with your legs widely separated, right? Now, if these two tracks are working fine, although sometimes, if the centers in our brain that are involved in higher processing of mental function are affected, especially in our multi-step pre-learned behavior, right? How many of you, if when asked to draw a star, you need to think about it? Or can you just do it without thinking? Just try doing it on a piece of paper in front of you right now. Are you able to draw a star?
Yes.
No problem, no thinking, right? It's a reflex. Because you have learned this before. Your brain, your premotor and your motor, supplementary motor area already have this all planned. They know what's the step, what's the movement. It's just press the button, jalan. For those of you who play sports, right or not? When you like a game like tennis or basketball, you don't need to think what you're going to do. You just do it, right or not? There's multiple steps, there's a lot of coordination involved, but that all comes from your higher mental function. Your brain knows what to do, even though it's complex. But if you have an apraxia, in spite of the strength of your muscle being good, the coordination and all being good, you have suddenly difficulty in either planning out a multi-step task or mimicking those tasks. All right? I'll show you why. I'll come to that first. So those are higher mental problems of motor function. But the more basic things are paralysis. This is pyramidal tract problems. Depending on where the tract is affected, you can get either weakness on half your body, that is known as hemiplegia or hemiparesis. This is commonly seen in stroke patients. You have a problem in just say your left brain is affected, the right side of your body is affected. That's how it works, the nerve. If the problem is in your spine, then you can get something called paraplegia, weakness of both your legs alone, but your hands are okay. If it's a higher part of your spine, that can even result in complete paralysis, or your brainstem, you can get quadriplegia. That means all four limbs you can't move. Sometimes you can get weakness in just one hand or one leg. This is usually not a central nervous system problem, but more of the peripheral nerve that is supplying the hand. Like for example, the hand is supplied by something called the brachial plexus. So there are plexus of nerves near the upper part of our arm. So sometimes that gets injured, for example, in a motor vehicle accident. So they completely lose function in one hand. All right. So these are examples of the type of paralysis. This is a picture of a patient with what is called facial palsy, weakness of the muscles of the facial expression. You notice she's got drooping of her lip on one side. She's usually, if you ask her to close her eye, she will not be able to close this eye completely. All right. So this is example of facial palsy, weakness of the facial muscles. How many fingers can you see in this slide, guys?
10.
Wow, very good. Huh? So you see, if you have a problem with the muscles of movement of your eyes, if one eye is not moving together with the other eye, you will end up with double vision, and whatever you look at will be like this. And that double vision will be more obvious when you look at the side in which the muscle of the eye is most affected. Okay, this is known as diplopia. So this is also a sort of a muscle disorder, but relating to eye movement. So see here, in a healthy person, your eyes will move together at all times so that you constantly maintain one vision, one image. But if one eye doesn't move properly because one of the muscles or the nerve supplying that muscle is affected, then you end up having two images, right? Not because they are not moving together. So that's what results in double vision. Okay, so I've talked to you about conscious movement weakness, of the limbs, of the face, of the eye movements. So subconscious movements, when you have problems of the cerebellum, you have problems related to your maintenance of balance mechanism and the regulation of fine movement. So that's where when you have a cerebellar pathology, this is a nice slide that I took from somewhere. So depending on which part of the cerebellum is affected, you can get something called ataxia, all right? Difficulty balancing, wide gait, they call, and when you have a problem with this coordination and balance, ataxia, you have something called so-called drunken gait, people who walk with their legs widely split apart, to try to balance. They have something called dysmetria. Remember in the morning I was pointing out the test where you touch your nose, and then the patient will be asked to touch the doctor's finger and move to and fro. So they should be able to do this smoothly, without overshooting, and they should be able to touch the target exactly tip of the nose, not one moment touch the eye, forehead, smoothly. So this is dysmetria. This diadochokinesia is the ability to do rapid alternating movements. If you look at my video stream, you will realize, up, down, up, down, up, down. Okay? And sometimes you get tremors of your limbs because the coordination function of the cerebellum is affected. All right? Okay. So besides that, besides conscious movement, weakness of movement or paralysis, if you have a problem of your basal ganglia, thalamus and all, you get involuntary movements, uncontrolled movement that you don't ask your body to do, but it decides to do on its own. So there are very many types of abnormal movement. You have tremors, tics, myoclonic jerks, choreoform movements. These are all they are due to different part of the brain being affected. Really not necessary for you all to know in any great detail, but just to understand how, why you get certain type of problems with, motor disorder, even though you can have a basal ganglia problem, but the patient can have good strength in their limbs. But they may have tremors, they may have abnormality in coordinating function, right? So I use chorea as an example. Chorea is like a dance-like movement, right? You spinning movement of the hand. Those days it was mistaken for something like a type of dance. It was nicknamed Saint Vitus's dance. Now, one of the common causes of chorea is due to pathology in the extrapyramidal system, particularly in an area known as the caudate nucleus, which we will be learning about in our talk on the basal ganglia. And one of the disorders that is passed down from generation to generation that causes chorea is a condition known as Huntington's disease, right? It's a degeneration of your caudate nucleus, and your extrapyramidal system, which results in choreoform abnormality in the limbs. Okay, so the image here basically shows how it's passed down from one generation to another, and as the person ages, the symptoms get worse and worse. And you notice in this brain sample, the caudate nucleus is actually shrunken. That's what they're trying to highlight here. All right, this is just an example of an abnormal movement. Okay, And last type of disorder that we get with motor function is known as an apraxia. So what is an apraxia? All your muscles work, but the part of the brain that plans and coordinates the movement of muscle has been injured or hurt. So, okay, I need you to do a task for me now. Now you draw, you draw a picture of a star, the star that you've drawn. I want you to put your pencil just outside that star, all right? Without looking at the paper, but looking through a mirror, are you able to draw a circle around the star? Can you all do that or not? Right? Okay, once again, you drew a star just now, right? For me, as a part of the thing I asked you to do. Now, put a pencil just outside that star, and without directly looking at the paper, maybe you can use a phone screen or an image screen or a mirror, draw a circle around the star. So this is an indirect action where you're going to look at a reflection and do it. But you find that you are able to do it, correct or not? Because your brain has already been programmed, you know how to draw a circle. You just have to, your brain can understand that you're looking at a mirror. So this is a higher mental processing of multi-step pre-learned task. All right? Guys, are you able to follow? Have I lost you?
Yes, sir.
So you see, if you have a motor apraxia, you will lose the ability to do this a simple thing like this. So there are different types of apraxia. They've got ideational apraxia, where when somebody asks you, okay, how would you mimic lighting a candle? So they're able to do it, but they cannot describe it if they ask to. So they cannot come up with the ideal steps. Ideal motor is they can tell you the steps, but they're not able to do it when you ask them to do it. Okay? You have constructional apraxia. When you ask somebody to draw a star, they're not able to, even though they've learned it before, because it's something pre-learned. It requires some coordination. You get dressing apraxia. You see, you guys dress every day. Nobody needs to teach you how to put your shirt on, how to wear your buttons, correct or not? Somebody with dressing apraxia will have problems with this because they have learned this action before, but the coordination function of the brain that tells you what's the next step is affected. All right. So yes, you may have a normal brain function, motor function, but yet you can have apraxia if the higher centers of motor function are affected. So this is a higher mental disorder of brain function, higher cortical function disorder. Okay. So here are some examples of apraxias, ideation of sequencing multi-step cannot do. Ideal motor, if you ask them to mimic that thing, they are not able to do it. Gaze apraxia, when you are asked to look at an object, follow an object, you have problems. But generally they can see. Gait apraxia is a condition where, now normally if somebody asks you to walk, you don't have a problem once you've learned how to walk as a child. But those who develop this gait apraxia or magnetic gait, this is commonly seen in elderly patients, actually, in a condition known as normal pressure hydrocephalus, buildup of water in the brain. So suddenly they forget how to walk. So they walk as though we will describe it as their feet are stuck to the ground. That's why they call it magnetic gait, as though you're just stuck down, and every step you take, you have to be so careful. Small steps. You don't take your normal big step, leg swings and all. No, every step is nearby, as though you are just learning how to walk like a baby. All right. So these are some examples of apraxias. Okay, so we've just gone through some of the disorders of vision and motor function. Now we talk about sensory disorders. You want to 1 minute break before we continue?
Doctor, can I have a question?
Yes, please.
Going back to the pyramidal and extrapyramidal system, right?
Yes,
so
yes.
One is pyramidal is the direct pathway, right? And extrapyramidal is the indirect pathway.
Exactly, yes.
Because of the direct and indirect pathway, so the extrapyramidal system will take a lot of time to process because it has to pass through the cerebellum and all that compared to pyramidal system, right?
Not exactly. You
Not
see,
exactly.
when you rather than using the direct and indirect pathway, the pyramidal tract is the one that innervates the conscious motor somatic muscles, that directly make you move. Okay. The extrapyramidal pathway are multiple pathways that coordinate this movement. I won't say it's indirect. I mean, in a way, but in fact, in some ways, the extrapyramidal pathway is faster because it coordinates the movement. You need to be moving more faster than just initiating and stopping. Correct or not?
Yes.
Fine tuning is actually harder. True or not?
Yeah.
Because it needs to influence velocity, direction of movement, coordinate the other muscle to relax while the conscious one is moving. So, I won't say it's slower lah. It's just it's a one is a direct effect, one is an indirect effect.
Okay. Well, if you refer to the speech motor muscles, okay, or motor speech processing, right?
Okay.
So can I say that if the patient requires to do non-speech tasks, right, like blowing candles atau kissing the cheek and all that, that involves the direct pathway, whereas the speech task, which requires to be able to produce the speech, is more towards the extrapyramidal system or indirect pathway.
No, that's a statement because
Okay.
speech map innovation is completely different. You see, you have your see, the motor pathway will be involved in the muscles that produce the speech. Correct or not?
Yes.
But that receives its instruction from the motor speech area, which is our Broca's area. If you talk about classical theories of motor pathway, don't talk about dorsal stream, ventral stream lah. So, but from Broca's area, the content and all is influenced by Broca's area, which is the inferior frontal gyrus.
Okay.
So a task like blowing out and all that comes from. That also comes from conscious motor function because you have to ask somebody to do it. True or not?
Yes.
But for those who have learnt it before, those with the extrapyramidal problem, they may be able to do it. But the smoothness or the ability for them to do it, especially if it's like a one set of actions, they will not be able to do unless you tell them, okay, now purse your lips, to blow out. You see or not? But they can individually do the actions.
Mm-hmm.
The extrapyramidal pathway, particularly the motor cortical motor areas, rather than saying extrapyramidal, the cortical motor areas that coordinate multi-step pre-learned pathway is your premotor and supplementary motor areas. When these are affected, they can do the things individually, but when you ask them to do it as in total as a concept, they have problems.
Okay. All right. Thank you. I have another question about the tick movement, right? Which is mostly associated with people with Tourette syndrome, right?
Yes, one of the conditions, yes.
Yeah. I watched a video that they reduce the tics movement by saying the F word, right? In between, so that it reduces the people's attention towards the tick, but more focus on their speech. How do you go about it?
I have to correct you on that. See, in Tourette syndrome, you basically have it's a condition where you have multiple recurrent, simple and complex verbal and motor tics. All right. So the motor tics are the ones you see, the jerking movement and all. But the verbal tics are also in the form of profanity, words that are said. It's not so much to reduce it, but it's part of the disorder. You have these verbal outbursts.
Oh, yeah.
All right. It's a form of a complex verbal tics.
So
and you suppress it. When you try to suppress it, then the patient gets more agitated. No, but it is not that they are saying, using profanity to take the attention away from the motor tics. The disorder itself, there is motor tics and there is verbal tics both occurring.
Okay. So how to reduce that tic movement, regardless verbal or motor?
Tics are complicated disorder. The spectrum includes one, behavioral therapy, drugs, treatment, and at the other end of the spectrum thing is we actually put in deep brain stimulators for patients with Tourette syndrome.
Okay.
All right. So that it will inhibit the amount of output, but this is honestly it's a very difficult condition to, one is to treat and also to live with, because the patients really cannot, it's very hard for them to control that urge. It's not something they're doing consciously. They're not swearing consciously,
Okay, then I understand.
It's a part of the complex verbal tics that they have.
And is there any reasons why most verbal tics include profanity but not maybe random words?
Yeah, there are a couple of theories behind that, but I will have to address that separately with you right now, because I think we will end up going very lateral. There's a lot of theories behind it because of the emotive content. I mean, verbal words have emotive content, and there's a part of balance between the emotional state of the person when they have these tics. Maybe I can address this separately with you. Write it in to me, send me an email, and I'll reply. Easier, because then at least, for the benefit of all your colleagues, at least we can finish up the lectures. Okay?
Okay, thank
Tourette
you.
syndrome is a very, very focused abnormal disorder, which is quite challenging to treat. Any questions on the motor disorders, in more general, paralysis or those sort of things? Okay, if not, we'll move on to sensory disorders. Okay, so there are so many different sensory modalities, that we have: vision, smell, touch, hearing, and equilibrium. These are all, different senses that make our experience of living better. So you have general sensations, which is like physical touch, pressure, vibration. You have temperature sensation, which is pain sensation. Chemical sensations, which comes from our limbs and our body. And you have special sensations, like what I mentioned: vision, hearing, taste, and smell. So we've covered vision. We'll talk about hearing at the end. Taste and smell are, a bit too wide. So we're just going to focus on, general sensory problems. So now, how does sensory information reach our brain? There are specific receptors in our skin and our body. There's pain, temperature, pressure receptor. You have your free nerve endings that carry pain. You have temperature receptors in our skin. You have joint position receptors within our joints, and all these carry information through the spinal cord to the thalamus, and from the thalamus, all right, they are related to the sensory cortex, which is in the parietal lobe. All right. So just imagine, just an example of how the receptor endings for pain, temperature, and fiber, and they are carried through the peripheral nerve to the spinal cord. They reach the second order neuron in the spinal cord. Then the second order neuron will cross to the opposite side and ascend. And depending on what modality of information, if it is a pain and temperature, it goes ascends in a tract known as the spinothalamic tract. If it is joint position sense, vibration, then it ascends in a tract known as the dorsal column. And finally carried to the thalamus. Remember the VPN, medial and lateral. This will be what? VPM or VPL? Can you all remember? Ventroposterolateral or ventroposteromedial if it's coming from the hand? Limb, Craig, Edward, good. So ventroposterolateral nucleus of the thalamus, where it will synapse with the third order neuron, which will carry information to the sensory cortex. So depending on where along this track the problem is, you have a different pattern of sensory loss. Okay, this quick, a run through of what I just explained. So the sensory cortex is located in the parietal lobe, the post-central gyrus, just behind the central gyrus between the frontal and parietal lobe. And next to that you have the somatosensory cortex and the association areas, the parietal lobe. So what does the sensory cortex do? It localizes the direction of a sense or the sensory stimulus. It helps you assess the criticality of how much it being relayed. It helps you recognize objects. For example, if it's touch, you can tell the texture of materials, and you can localize where is pain and temperature coming from, whether the single source is a double source, something known as 2-point discrimination. Okay, this is just for sensation. the same applies in the sensory cortex will also process hearing, which visual input, hearing input, and various other sensations. But now, for pure sensory disorders, I'm just talking about this mainly touch, pain, temperature. Okay, so that what are the common type of sensory abnormality? You can have complete loss of sensation. All right, this is absence or anesthesia, absence of sensation. Completely, you cannot feel it. All right, or you can get something called paresthesia. Paresthesia is pins and needles sensation in the limbs. How many of you have realized that if you sit too long and then suddenly you get up, you feel your legs are all, like pins and needles. This is known as paresthesia because of due to your posturing, the peripheral nerve that supplies the limb, is placed in a bad posture or doesn't receive enough oxygen, and naturally, you get these pins and needles. Sometimes you even go on to get neuropathic pain. That means what is not supposed to induce pain in your body, but just because of the abnormality in how the nerve sensory information is carried. What should be carried as just touch is carried as pain, and you get an abnormal pain in your limb even though there's no damage to tissue going on. So that is known as neuropathic pain. Right? Now, if the loss of sensation involves a whole half of your body, that is known as hemianesthesia. This is typically seen in problems involving our cerebellar cortex, our parietal lobe or thalamus. Now, if the pathway that carries information from the peripheral receptor through the spinal cord to the thalamus is intact, sometimes you are able to feel the sensation. All right. However, your ability to recognize and process the sensory information gets affected. Something similar to the visual, higher mental problems of visual function that I mentioned. Remember, recognizing faces, tracing movements, simultaneous images in your vision. So, the sensory abnormality, where you have problems with recognizing sensory input is known as agnosia. All right. The simplest and commonest form of agnosia is something known as astereognosis. The second last thing listed in this list. So astereognosis arises from the word a, to not be able to do. Stereo means touch and gnosis is recognize. So what do you mean by astereognosis? Now, if I were to ask you or to place a key or a coin in your hand with you when your eyes are closed and I ask you to just feel it and recognize and tell me what it is, most of you who have a normal sensory cortex will be able to do this. Right or not? Because your brain is able to process the information. Oh, when you touch, this feels round. The size is corresponding and the weight is corresponding to a coin. So this is a coin. I can even go further to say that you probably can recognize 20 cent, 10 cent, 5 cent, right or not? Dollar notes, maybe not so easy, but coins surely. Key. Similarly, if I put a frog in your hand, if your eyes are closed, you will know it's something slimy, and it's because of your ability of your brain to recognize the sensory input, correlate with your previous memory and understanding, and recognize it. So this is the loss of this ability is known as astereognosis. Typically occurs if you have a pathology in your parietal lobe. So what will happen is you will have astereognosis on the opposite side of your body. So your hand and your leg will lose the ability to recognize tactile sensation. Similarly, if you have a problem in your parietal lobe, you can get sensory neglect or spatial neglect. You neglect sensory input from that half of your body. Depending on what sensory modality is affected, right? It can be visual neglect if it's more posterior, or it can be sensory or touch neglect, depending on the affected modality. Now, whenever we talk about motor and sensory disorders, I just want to introduce this concept of upper and lower motor neuron lesions. Now, when the pathology affects the nerve structure within the central nervous system, meaning the brain and the spinal cord, they give rise to a series of, a pattern of disorder which is different from when it affects the nerve that comes out of the spinal cord, the peripheral nervous system. So, based on the combination of symptoms, this is just nice to know, nothing you really need to know. This is what we teach our young medical students about how to differentiate causes of weakness in the limbs, right? So, in a pathology involving the central nervous system, the brain and the spinal cord, we name it upper motor neuron lesions. So they will have symptoms like, other than weakness, the limb becomes stiff and spastic, right? And you will also have sensory defects depending on which part of the system is affected, with loss of 2-point discrimination, vibration, proprioception, pain, temperature, depending on, which tract is affected. Low motor neuron, on the other hand, the limbs become soft, flaccid, they lose its power. It's a bit different. So, see, sometimes patients who have had a stroke, the limbs become very stiff and they bend, right over the body. Compared to somebody who has had a nerve cut, the limb just hangs free at the on the side of the body. So these are all some of the clinical features that we differentiate. Both of the limbs are paralyzed, but the how they end up is a bit different. So that's why this concept is something we always use when we're describing motor pathology, upper and lower motor neuron. This is for pyramidal tract pathology only, guys, not extra pyramidal. Okay, the last the disorders I'm going to cover today is disorders of hearing. I mean, these are all more for you all to just have an overview of how pathologies affect your brain. I think the most important takeaway message for this lecture is for you all to know the visual pathway and how the vision can be affected depending on where the lesions occur. Okay, so disorders of hearing. When we talk about hearing, you need to understand the anatomy that is involved in hearing. So this image gives a summary of that. When we hear a sound, the sound waves are carried through our outer ear to our eardrum. All right. This eardrum will vibrate from the sound created by the airwaves, and this vibration is translated to 3 bones, right? The incus, malleus, and stapedius, which transmit this movement of the eardrum to an organ known as the cochlea. So the cochlea is like this, shell-shaped structure, spiral structure, which contains fluid inside. So when this vibration from the eardrum translates to the fluid within the cochlea, there's movement of this fluid. No. Imagine if you take your hand and you hit it into a pot of water or a pond, there will be ripples form. Same thing. So this vibration forms ripples in the fluid inside the cochlea, and there are fine hair cells inside the cochlea that move when the fluid, when there's a ripple in the fluid. So that, depending on the extent of that ripple of the movement of the fluid, the hair cells are activated. No, there are so many hair cells within this spiral that are triggered by different intensity and frequency, right? Something more central will require a stronger stimulus to trigger. Something more peripheral, less. That's why it's arranged in such an interesting spiral shape. So essentially, when hair cells are stimulated, they trigger impulse within the auditory nerve. So the auditory nerve will carry impulses. The auditory nerve, remember, is your 8th cranial nerve, will carry impulses from your ear to your brainstem. It will go to the cochlear nucleus, and then from there it is transmitted upwards through a tract known as the lateral lemniscus to the brainstem, and then from the brainstem to the medial geniculate body, finally to the auditory cortex, which is in the temporal lobes. Now, interestingly, if you look at this, your innervation from both your ears are carried to both brains, right and left. So that's why it's very rare for you to lose your hearing in one ear due to a brain pathology, unless the pathology is in both sides of your brain. This is very interesting. So your hearing is fairly well protected thing. So common cause of hearing loss in one ear is usually a problem occurring with the outer ear mechanism or the nerve itself before it reaches the brainstem. Okay. Now, there are another group of these structures up here, which are known as the semicircular canals. They work together in tandem with the cochlear nerve, but their responsibility is in the maintenance of balance, which is why your 8th cranial nerve is known as your vestibular cochlear nerve. It has cochlear component, which carries hearing function, and vestibular component that is involved in the maintenance of balance. But for hearing, it is only the cochlear nerve that carries function. All right. So do you have different? Yeah, go ahead.
Sorry. I would like to ask you some because I had that is my son when he born. They checked the ears and then they said that he cannot hear some of the vocals. Which
Mhm.
area in the auditory receiving centers, where is this issue? Where is the damage it comes?
Okay. Let's go through the disorders first before I answer this question. It'll be a bit easier that way, all right? So,
Okay.
see, when you have a hearing disorder, you have either peripheral hearing problems or central hearing loss, okay? Now, peripheral hearing disorders are usually related to the ear's hearing mechanism. They have two different types. One is known as conductive hearing loss, all right? This is because there's failure of sound conduction from outside in through the external ear, the eardrum, to the cochlea. So this is caused by disruption. Either you have an injury to your eardrum or an infection in your ear, all right, or because the bones of the remember I mentioned the eardrum bones, the incus, malleus, and stapedius, they become hardened, autosclerosis, so they don't vibrate properly. So this causes what is known as conductive hearing loss, all right, or the cochlea and the auditory nerve can get damaged, and this condition is known as sensory neural hearing loss. So there are a lot of causes of sensory neural hearing loss due to infection when you are young, due to an injury, or due to a tumor occurring near the auditory nerve, or due to some of the common drugs like antibiotics and anti-TB medication. This can all result in injury to the nerve. So if you have a problem with either a conductive or sensory neural hearing loss affecting your hearing, you typically get loss of hearing in 1 year. Of course, unfortunately, sometimes people get it in both, but it's more often in 1 year, so that you lose hearing in the ear. Alternatively, you may have only problems with listening to certain certain types of hearing loss. But before that, I just give you an example of a kind of diseases that affect your hearing. This is a condition known as neurofibromatosis type 2. You notice these two white things, right? These are tumors that arise from the vestibular and cochlear nerves, right? These white things are tumors, that one of the common causes of loss of hearing in patients. All right. So this is just something I just did a week ago. So a young gentleman with a large tumor, notice this white thing. This is a large tumor arising from the vestibulocochlear nerve and facial nerve, and see, this is at the end of the surgery, the tumor has been removed. There's just a little bit left, and you can see the nerve and the brainstem behind it. So I mean, this is just one of the common causes of injury to the cochlear nerve, vestibulocochlear nerve, that results in hearing loss. Okay, so then we talk about central auditory processing. This is usually problems in your brain, all right? So that's where you have problems with detecting a pattern in the sound, frequency, time, the amplitude and space, or it may not be as bad as a cognitive language disorder, which is more of a purely higher mental function problem. But they have you have combination of problems with understanding, reading, and writing. These are known as your cortical syndrome. So, okay, one of the commonest thing is your cortical deafness. Cortical deafness is a disorder where the patient is unable to hear sound, but has no damage to the anatomy of the ear. All right. These are usually when you test audiometry, the patients have normal reflexes in the brain, but they are still not able to hear. This is known as cortical deafness, and is usually a bilateral lesion of the superior temporal gyrus, right? So some of the common conditions cause this is a temporal lobe stroke, or bilateral brain tumor, or herpes simplex infection in the temporal lobes. These are some of the common conditions that cause cortical deafness. Then you have something called auditory agnosia. Remember, we learned that agnosia is a sensory symptom where you're not able to make sense of the hearing. So to answer the question of your colleague just now, I mean, this is possible that he may have this condition, but to be honest, I don't like to pass a clinical opinion just based on one fact. Usually it will require an assessment of his whole cognitive function, his speech development, looking at his audiometry and his brainstem reflexes, right, and his age, before you can decide that this is exactly the problem, right? Now, okay, so I did explain to you, an agnosia is a failure to recognize environmental stimulus despite intact sensory function. So a patient with auditory agnosia have disorder of perception of certain sounds, complex sounds, right? They sometimes and include could be speech, that is known as pure word deafness. They just cannot recognize words and speech. They can recognize sounds around them, all right? Or they may not be able to recognize music, that's known as amusia. Or sometimes environmental sounds, created by motor vehicles, cooking apparatus, kitchen. So this is environmental sound agnosia. There's often an overlaps in the different types of, hearing loss. You can have combination of word deafness, amusia, or environmental deafness and amusia, But and the hypothesis behind this is they can hear the sound, but the ability of the brain to process the information about the depth, the space, and the pattern and all is affected. So usually when we test this, we give them a series of words, you let them listen to music, environmental sound, and you see which of these they can actually hear or not hear. If you do a brainstem auditory test, the brain area responsible for hearing will light up. So that's why this one requires a detailed cognitive assessment, before you decide what is the actual pathology, all right? And sometimes they also have coexisting peripheral and cortical problems, So, in this kind of situations, right, and we would do an MRI to look for whether the temporal lobe is affected, whether there's any other hemispheric problems, motor weakness, speech weakness, visual weakness to tie in the pathology. So how old is your son, by the way? I know, I don't like to discuss about a patient or a person, a relative of yours, with all your friends here. But generally, I can just give you some basic information, Elif.
He's 14 years old.
Oh, okay. And is his school development okay so far? Is he going to a normal school?
Yeah. Everything is okay. But
Okay,
sometimes the teachers are telling me that certain sounds that when he comes to me and he said that I don't understand, mommy. I think is somehow is this area is not he had it from the birth. Always had the ear problem.
You know what I would suggest? If you have not seen a doctor yet, first thing you need to do is just do a audiometry to see whether he is not able to hear sounds of a particular frequency. That may be more of a peripheral ear problem rather than a central problem. That can be easily corrected. If it's a central problem, usually there will be other issues, and his education, his academic performance would have been affected. Because, for example, if you have problems recognizing speech and all, it will affect your educational progress. So, if the fact that you're telling me that his education and his studies and all is quite good, that points more to a peripheral problem of hearing rather than a central problem. He may have part of his cochlea damaged because of an infection, or hearing a very loud sound somewhere along the way, and that's why he's only able to hear certain sounds of certain frequency. So that's just one of the possibilities, lah.
Yeah. Okay. Thank you.
Yeah, I suggest that you see audiologist for the hearing assessment, to look at it. Yeah, a series of assessment can identify the problem, whether it's at peripheral level or at cortical level.
Okay. Do that. Thank you.
All right, guys. Okay, guys. So we are done for the lecture on disorders as just an overview, and the last part will be on the basal ganglia and the limbic system. All right. So I'm going to give you a little short break. Yeah, we are going to give you a short, about 5 minutes break, and then we will come back for the last lecture.